I'd like to call up Lisa Waddell. Lisa is joining us from Melbourne. It's very nice to have her come to visit us. She's worked on the last 2 updates of the Antibiotic Therapeutic Guidelines, which, for those of you that don't know, this is really the trusted Bible for not only infectious diseases physicians, but pharmacists and nurses and medical staff all around the country to help with the differentiating what treatments should be used for particular conditions and also what dose of drugs should be used. And so the kind of work that we do very much, I hope, informs the decisions that are made at Therapeutic Guidelines. So Lisa, come invite you up, please.
Cool. Thank you, Jason. It was very kind of you to invite me here. We worked on the last version of Antibiotic Guidelines together, which was wonderful. Okay, so how does literature inform antimicrobial dosages and therapeutic guidelines? So today I'll be giving you an overview of guideline development, because in order to understand how we come to determining the antimicrobial dosage recommendations, you have to have a slight context of how the guidelines are developed. So first of all, I'd like to point out that therapeutic guidelines are not clinical practice guidelines. So that normally clinical practice guidelines are developed using frameworks such as AGREE-2 and IOM, and underpinned by methodologies such as GRADE. So AGREE-2 here, as you can see, there's an example of it, and that is a framework for developing guideline methodologies and assessing guideline transparency. So development of therapeutic guidelines, I won't go into huge detail here because we don't have enough time, but they are still, although not clinical practice guidelines, are underpinned by some of the key tenets of AGREE-2. So, for example, I think the most notable thing that shows that we're not clinical practice guidelines is the lack of grading of recommendations, but there are quite a few things that remain important. So, in particular, editorial independence, ensuring adequate expert group engagement, managing conflicts of interest, and of course having specific and clear recommendations. So to touch on external stakeholder engagement, for example, at the beginning of each update to a guideline, we will send out a call for feedback to all the relevant professional societies and organisations. And then I think it's important to touch on expert group composition. So for this update that's currently underway, we have over 100 experts from across the country, and they are placed into 6 different multidisciplinary different groups. Then we also, within this, I'm getting a phone call on my watch. Within these expert groups, we also have some subspecialty streams. And so we have a paediatric subgroup comprised of paediatric ID and clinical ID physicians, clinical microbiologists and pharmacists, and a clinical microbiology subgroup comprised of clinical microbiologists and pharmacists with expertise in PK/PD. So then we need to think about the key resources that these experts are appraising. So I think similarly to a clinical practice guideline where you're looking at similar resources, so randomised controlled trials, the difference here is that when therapeutic guidelines, the strength of therapeutic guidelines process, I feel like I'm saying therapeutic guidelines so many times, it's because it's been beaten into me. I'm not allowed to say TG. And so it seems very odd. And we consider the literature, but we also consider the practicalities of the literature and the experience of the clinicians within Australia. And so in addition to also what I'd point out, rather than going through every item on this list, is that unlike clinical practice guidelines, we also use clinical practice guidelines as a reference. And very kindly, we have a great, well, not kindly, because we have it. We have a relationship with the Australian Commission in Safety and Quality in Healthcare, and they kindly provide us with aura resistance data when requested for targeted pathogens and populations. So we're able to get quite recent data to inform our recommendations. So then we come to the challenges of applying that breadth of literature to form antimicrobial recommendations. And I think we've touched on already the lack of data. There's an absence of data, and then even when we do have data, there's quite often gaps. So you'll see what I mean when I bring up an example. Then we also need to consider the relevance of data when we're making antimicrobial recommendations. So, for example, in acute appendicitis, for example, most of the randomised controlled trial data is in children. So how do we attribute that data to adults? Then also, we'll all be mindful of the changing definitions of sepsis in the last 10 or 15 years. So how do we know how to attribute data when the patient groups aren't necessarily comparable? And then we also need to consider whether the literature available is relevant to the Australian context. So I'm thinking of the local antibiogram, and so is the epidemiology where the trial was run similar to that of Australia? Then, while we're thinking about the local antibiogram, we need to think about the minimum inhibitory concentration and how the MICs applied at the time that data was created compared to the MICs and the breakpoints that are available now. So this is really important because we're looking at antimicrobial resistance data to inform our antimicrobial choice, and furthermore, the breakpoints are informed basically by this, and we need to ensure that in order to reach the breakpoint, that in order for the antimicrobial to work, it needs to be reaching the correct site and at an efficient dose in order to kill the pathogen. I feel like I butchered that. I had written it beautifully, and then in this sentence, it's gone. And so then making it more difficult is that there are different clinical microbiology standards being used in Australia. So UCAST and CLSI both have different breakpoints and dosages that underpin them. So then I've got an example to show you how we've considered this. So in the last version, so in this case, I'm bucking the trend and not discussing bling, but I did want to mention that we are considering the data and that trial, along with the meta-analysis that accompanied it in JAMA in the next update of Therapeutic Guidelines. So in the last version, Jason may remember, there was that was published in 2019. There was a question as to whether we should increase the dose of ceftriaxone from 1 gram to 2 grams in the treatment of intra-abdominal infections. So what we did was we looked at international guidelines, and they both recommended 1 to 2 grams. And then at the time, for context, the standard clinical microbiology dose underpinning Enterobacterales was 1 gram. So then we come to randomised control trial data. There is no randomised control trial data comparing 1 and 2 grams head to head. But when we looked at the data in intra-abdominal infections, all of them, except for the little one from 1991, used 2 grams. So that was quite fascinating. And what was also interesting is if you'll notice that a lot of these papers, there's only certain intra-abdominal infections. Not every intra-abdominal infection has had ceftriaxone studied in it. And so there needs to be careful extrapolation when you're applying that data to a range of intra-abdominal infections. And you also need to consider the penetration, for example, into abscesses, the biliary tract, and the peritoneal cavity. Then my lovely graph is covering up my words, but we also need to look at PK PD data and the MICs. So at the time, Enterobacterales breakpoints for susceptible pathogens were generally below 1, but there was and continues to be increasing prevalence of ESBL E. coli. And so we did think theoretically more ESBL E. coli isolates would be able to respond to 2 grams of ceftriaxone rather than 1 gram. So on the basis of that, and also that the majority of the clinical trial data used 2 grams, and there was a lack of adverse effects associated with 2 grams compared to 1 gram, the dose was increased, also considering penetration data. Then, interestingly, since then, UCAST standard dose of ceftriaxone has increased to 2 grams daily. Then the CLSI dose remains at 1 gram. So it's interesting that it continues to be different. So that's that. My final thoughts are many evidence gaps remain, and when there's a gap, clinicians at the coalface still need drug recommendations. And so when that evidence is missing, we need to have, we rely on expert consensus and also drawing on first principles. For this current update to therapeutic guidelines, the expert group is compiling a list of evidence gaps, and we're also documenting them, and they will be available for publication. They won't be prioritised because we don't have expertise in that. And I'd also like to mention it's pivotal to critically appraise not just the strength and certainty of evidence and how it fits in the bigger picture, and to think about the multiple inputs and how they may be slightly different depending on the context.
That's great, Lisa. That gives a fantastic insight to us about, for those of us that do these pharmacokinetic studies and wonder where they're going, to see how they get appraised and then move forward into a guideline which is used by so many people around the country, and actually beyond that, because the Therapeutic Guidelines does donate their resources to other less fortunate countries. So thanks, Lisa, very much.